Hi, I'm Susana Vacas. I'm an anesthesiologist at the University of California, Los Angeles. What I would like to talk about today is the impact of surgery and anesthesia in the brain health of our patients. I have no conflicts of interest. I do have a patent for the modulators of the eukaryotic initiation factor 2 alpha pathway, but I will not be speaking of this today. So, why does this matter? So, I would like to start telling you that preoperative cognitive dysfunction is even more common than you think. This is a nice infographic cartoon that was published in anesthesiology about 2 years ago. So, what happens is that cognitive impairment is associated with worse surgical outcomes, not only discharge other than home, but also the increase of delirium and leads to a longer hospital stay. And the interesting is that the healthcare costs that are attributed to delirium are more than $164 billion per year in the United States alone. This increasing public awareness of postoperative cognitive problems and also our patients that are becoming increasingly worried led in part to the launch in 2016 of the American Society of Anesthesiologists Brain Health Initiative. One of the main goals was to accelerate implementation of current strategies that were associated with the reduction of delirium. And the first step was that it was so clear that there was a need to clarify and define terms. So, a multidisciplinary international team worked on a more reflective and specific nomenclature, one that was more aligned with the diagnostic terminology used for cognitive dysfunction in the medical community. This work was so important that it was published in 6 journals simultaneously. So, perioperative neurocognitive disorders basically is an overarching term that includes acute changes such as delirium, which occur immediately post-operatively up to 7 days after surgery, or delayed neurocognitive recovery when these changes last up to 30 days. If the changes last up to 12 months after surgery, then they use the term the mild NCD, neurocognitive disorder, or POCD. So now you're asking, are these the same diseases? Are there a continuum of diseases? Is delirium associated to cognitive dysfunction? The scientific community is actually torn about this. There is evidence that supports both the splitters, with those who view these as completely separate disorders, and the lumpers that view these disorders as two manifestations of the same spectrum of PND. This group found that there was an association between preoperative cognitive status and delirium, but they also found that there was an association between patients that developed delirium and then the subsequent dementia with an increased odds ratio of 5. So it seems like that they are connected. Sharon Inouye and their group showed that this cognitive decline after surgery has almost like a biphasic and a shape, which is more accelerated in persons that have developed the delirium. Although then the pace of long-term decline is similar to that seen in people with mild cognitive impairment. And a recent study from last year, this is an observational study with 560 participants, over which 24 developed delirium. And this group showed that delirium significantly increased the risk of postoperative cognitive dysfunction in the first month of surgery, and that this relationship did not hold in the longer term. So at 6 months, whether you had delirium, whether you had not had delirium, it was the same. So they do think that this postoperative delirium and postoperative cognitive dysfunction would be distinct manifestations of perioperative neurocognitive diseases and could be triggered by interactions between surgery, anesthesia, and one or more preoperative vulnerabilities, such as inflammation, preclinical Alzheimer pathology, or even blood-brain barrier dysfunction. But what we know is that cognitive dysfunction is common in adult patients of all ages at hospital discharge. And we also know that in patients aged 6 years old, they are at a significant risk for long-term cognitive problems. So patients with PND are at risk of death in their first year after surgery. Our group tried to understand why this was happening. So using an animal model of orthopedical surgical model where we mimicked a tibia fracture, very common procedure in the elderly patients, we did a trace fear conditioning paradigm, which is basically a memory test. Animals that have their memory intact would freeze once they were put back in the same box before surgery. And we saw that in short-term anesthesia, these animals were freezing, which meant that their memory was intact. While the animals that were submitted to anesthesia and surgery, they would freeze less, which means that their memory was not up to what it was before they had this orthopedic surgical module. We wanted to understand if these changes were happening systemically. And yes, there was an increase of cytokines such as IL-6, TNF-alpha, and IL-1 beta, which means that these animals, after surgery, there is an inflammatory systemic response. And we also went a little bit further. We saw that these changes also occurred in the brain. After surgery and anesthesia, there was an increase of IL-6 mRNA expression, TNF-alpha, IL-1 beta, and MCP-1. We then recruited patients, we recruited humans that were undergoing major knee surgery because we wanted to make sure that what was happening in the animals was also correlated with what was happening in humans. So here all patients had a spinal catheter placed at the time of the spinal anesthesia and was left for 24 hours. And we could see that we then collected CSF samples and we could see that there was increase of all these inflammatory markers, IL-6, IL-8, TNF-alpha. And then, but what we weren't sure at the time is if what was happening was due to the bone marrow-derived macrophages that was going to the brain, or if it was the resident microglia that was actually creating damage. So we went back to our animal models, and we use pharmacologically approach where we depleted all systemic macrophages. And it was true, after depleting the systemic macrophages with clotrimazole, we saw that these animals were doing better. And that's how we kind of understood that it was the circulating bone marrow-derived macrophages that were being activated and signaled to reach the brain. So in a small summary, what's happening after trauma, such as surgeries, there is passive release of HMGB1, a damage-associated molecular pattern that through pattern recognition receptors on bone marrow-derived macrophages leads to activation of NF-kappa B and the release of cytokines. Through disrupted blood-brain barrier, and these bone marrow-derived macrophages reach the hippocampus attracted by MCP1, where they generate a neuroinflammatory response that interferes with memory. Now you could ask me, why does not this perioperative neurocognitive disorders do not occur in all traumas if I'm just telling you that trauma-induced inflammation is the basis? And this is where the concept of vulnerable brain comes, whether it's inpatient care-related factors or patient-related factors. And where we should be looking is at modifiable risk factors that we can, as physicians, interact and improve the care of the patients. In 1998, there was an international multi-center study on long-term postoperative cognitive dysfunction. They found several risk factors that were associated with PND. So there were a number of multi-center studies that were conducted in years that followed. And we now know that there are several risk factors. There's no discussion about this. And this has been extensively studied in the literature. What we are trying now to do is to try and divide these risk factors to modifiable, partial modifiable, or non-modifiable, such as age. in recognizing the necessity for the quality improvement, particularly in the geriatric surgical patient, several best practices were created around the optimal perioperative care. The American College of Surgeons, in collaboration with the American Geriatric Societies, developed their guidelines. The European Society of Anesthesiologists also published evidence-based and consensus-based guidelines on the reduction of postoperative delirium. And all these guidelines are target interventions where there is a patient that has depression, and we should be looking at treatment and counseling, hypertension, perform a full cardiac evaluation to these patients, treat sleep disorders, not only the perioperative glycemic control, but also diabetes control. When these patients are scheduled for surgery, a full perioperative assessment has to be done. Treatment of alcohol and substance abuse disorders, review all medications, avoid polypharmacy as possible, and definitely avoid routine use of benzodiazepines. A nutritional plan with supplementation if indicated, directed pain history and ongoing education, and also consider referral if you think that family and social support system are inadequate. Also, intraoperative measures have appeal to impact the course of PND. Although it seems intuitive that regional anesthesia should provide a benefit for perioperative brain health as compared to general anesthesia, we now know that there is no anesthetic per se. And so there are several medications that should be avoided. Also avoid relative hypotension, maintain hypothermia, and although controversial, there is strong support to the use of intraoperative brain monitoring to minimize the anesthetic dose. So in summary, I think a half a century ago, due to the adverse effects of anesthetics on the brain, surgeons in patients over the age of 65 were confined to unequivocally necessary cases. However, surgical advances now have compelled this option of complex surgery to be performed even in these high-risk populations. So best practices and interventions can begin before surgery and extend well into the discharge period. And to be most effective, these strategies require the involvement of an interdisciplinary healthcare team, comprehensive systems of care, and family engagement. Thank you very much.